And then the next category is malignancy. So we all know that cancers can also cause fever, usually low grade and usually chronic, and these patients present with multiple other symptoms as well. So the most common cancers that cause fever in adults would be your Hodgkin's and non-Hodgkin's lymphomas that present with constitutional symptoms, fever being one of them. Then you have CML, which is chronic myeloid leukemia, and then usually people have anemia, splenomegaly, and thrombocytopenia with that. And you're all familiar with Philadelphia chromosome, where there is translocation of ABL, BCR on chromosomes 9 and 22. The other main cancers that, although not as common compared to some of the other cancers in the body, but these are the ones who that will present with fever sometimes as a chief complaint. So always look for these. So renal cell cancer, hepatocellular cancer, and then other cancers that metastasize to the liver. So these are adult cancers, and then there are malignancies in children. So leukemias, especially ALL, and lymphomas will present with will present with fever. Usually children have, in addition to fever, they have malaise and generalized bone pain. So it's not usually just one part of the body or one bone or one joint. It's actually generalized bone pain that they have. And then weight loss, if present, should definitely raise a red flag. With lymphomas, they not only have fever and malaise and all these symptoms, but also there is enlargement of lymph nodes. So obviously this means that we should look for lymph nodes when we're doing the physical exam. So that's how it becomes very important. Here is just some common lymph nodes that can be enlarged, and when they are in the absence of infection, should raise a suspicion for malignancy. So epitrochlear lymph nodes usually should not be palpable, but if they are, and here is a rough measurement or size. If it's larger than this, then we should definitely work up, but you don't have to remember these numbers. Inguinal lymph nodes, if they are enlarged, and of course then if cervical lymph nodes are enlarged, much more enlarged, then we should definitely work that patient up. Now remember that among these, especially the cervical lymph nodes, are going to be enlarged quite a bit for various other reasons, because any head and neck infection will cause enlargement of the lymph nodes in the cervical chain. But this is we're talking about when we've ruled out infection, we know that this is not an acute enlargement, then definitely look for underlying causes as malignancy. Here is a slide showing ALL smear. So there are some blast cells. So just a quick review on this. And then this is an important slide showing Burkitt lymphoma dissection. So there is Epstein-Barr virus, which is extremely important virus because it can cause Burkitt lymphoma in Asian population. Usually it's a lymphoma in the head and neck area, and you can notice a mass. The biopsy is going to show a starry sky pattern, so very important to remember. This question gets asked a lot in the boards and some exams. So Burkitt lymphoma with EBV virus, and then there is a starry sky pattern on the slide. The next category is connective tissue disorders. So we have people coming in with these symptoms usually. So it's constitutional symptoms, and then there are multiple connective tissue disorders that are linked with it. Now this is not, of course, the entire list of these disorders. This is just a brief list just to show that how these abnormalities or pathologies can be associated with these symptoms. So this is just a quick review. We're not going into depth here. So people will come in with low-grade fever, which is usually chronic. They have malaise, arthralgias, and myalgias, and then rashes or skin rash is going to be the biggest key feature in this. So you can notice that if you go back to your malignancy slide, all of the rest of the symptoms are going to be present in patients who come in with cancer as a cause of fever. But if they have rash, that is a distinct feature linked with connective tissue disorders. So when you have rashes and also family history of autoimmune disorders, then definitely it should raise a suspicion of connective tissue disorder. Now also remember that not every connective tissue disorder will have rash, but this is just talking about majority. So just remember rash whenever present, look for this. These are the some of the disorders. I'm not going to talk about all of these in detail here. We'll cover a little bit more of this in fatigue. But you have lupus, rheumatoid arthritis, interstitial lung disease, Sjogren syndrome, and systemic sclerosis, and many more. So anyhow, let's move on. So then the next category is drug fever. So drug fever is interesting because instead of usually drugs causing relief of fever or relieving from fever, in this case are inducing fever. So how do we recognize that? How do we know that our patient is actually taking the drug that is causing the fever versus a patient is just not getting better despite taking the medicine, and the underlying infection is just very severe? So here are a few things that we should keep in mind in terms of clinical features. So first of all, remember that these are the main drugs. So there are 3 A's and then an I. So you have anticonvulsants, antibiotics, and allopurinol, and then you have immunosuppressants, for example, methotrexate, azathioprine, and some of the others. So remember these 3 A's and an I. Among this, you can see that antibiotics are used to treat infection. But then again, how do you know this is antibiotic-induced fever versus underlying infection not getting better despite antibiotics? So this is what you keep in mind. You remember that there are 3 different ways that drugs can cause fever. So there are 3 different underlying pathophysiologic mechanisms. The first one is hypersensitivity reaction. This is the mildest form, and then you can get more and more severe forms. So hypersensitivity reaction is usually IgE mediated. So this is just a standalone allergic reaction. Usually people can present with either SJS or hypersensitivity vasculitis, which is more severe, and then DRESS, which is a syndrome, is much more severe. So people are going to be much more sick here. So and we'll talk a little bit more about it. The next different pathophysiologic mechanism for drug fever would be Jerisch-Herxheimer reaction. This is where people take antibiotics and they already have an underlying infection that will precipitate a toxin-mediated reaction, and that's how they get fever. So patients have to have something like syphilis or another infection similar to it, and then when they take the antibiotic, then fever sets in. The next is malignant hyperthermia and neuroleptic malignant syndrome. These are fevers caused directly by the medicine. So this is not an immune mediated reaction. It's not necessarily a toxin mediated reaction. This is direct drug related fever. So drug actually causes the hyperthermia. So Haldol or haloperidol is one very commonly used drug that will cause neuroleptic malignant syndrome. That's why we try to be very careful when prescribing it. And then succinylcholine can also cause malignant hyperthermia. In both cases, of course, you will discontinue the drug and then try to cool the body. So let's talk a little bit more in detail about these. So here is hypersensitivity vasculitis. So remember this. People will come in with fever and they usually have vasculitis, rash, palpable purpura, and lymphadenopathy. So you'll see that lower extremity usually is involved, and whenever they are taking antibiotics and they were obviously sick with something else before, but now they've developed a new rash and it looks like this. It's vasculitic and it's usually palpable along with the lymph nodes, which may or may not be enlarged anyway beforehand. Then you will say, okay, you'll start thinking about hypersensitivity vasculitis. Here is another drug reaction. So this is a target lesion. So remember from your dermatology that this is erythema multiforme. This is also drug induced. So when you see lesions like this, people can have erythema multiforme. So remember these two distinct categories or different pathologies that you can see with drugs, and antibiotics would be the biggest reason. The next is SJS or Stevens-Johnson syndrome. So this is another board favorite syndrome. A lot of questions get asked about it. So people can have, after started taking the drug, they start having developing fever. Usually they have mucocutaneous reaction. So it's not your palpable purpura or a simple erythema or a target lesion. It is bullous lesion. So you see a raised bullous lesion. So you see the like like a bulla that is filled with fluid. And if it is less than 10% of the body surface, then it is SJS. If it is more than 10% of the body surface, then it's of course just more severe. It's a similar phenomena, but then it is TEN. So just remember SJS here. The next more severe form is DRESS. So that is drug reaction with eosinophilia and systemic symptoms. So just like the name suggests, that's all that it contains. So people have morbilliform rash, so very, very flat erythematous, generalized confluent rash. So you can see there is a lot of erythema here. It's very flat, so it's not raised or anything like that. And then along with that, they have a lot of systemic symptoms. So not only fever, they have lymphadenopathy, and when you do their labs, that's how you know it is probably DRESS, because there is eosinophilia. So you can see just by looking at these things, you can see that the distinguishing features here would be that with DRESS you will have eosinophilia, with SJS you will have bullae, and then with the hypersensitivity vasculitis you have palpable purpura. So just remember those distinguishing features. Next is a few more infections. So again, these are bacterial infections, and we did not cover them too much earlier on because these are just very simple. So just quickly going over it, skin infections of course can cause fever as well. So the biggest one being cellulitis. So people can get cellulitis usually of the lower extremities. Sometimes it can be other parts of the body too, but this is very common. So patient will have a tender erythematous part of the body or extremity where infection is set in, and the other possibility would be an abscess. So skin abscess is under the dermis, cellulitis is involving the dermis. So that is the distinguishing feature. So you can actually palpate a very isolated abscess, so you will be able to feel a mass here. Here you don't feel any mass, you just can sometimes appreciate some induration, but usually it's not a distinct boil or a mass. So the other name for abscess, some people call it boil, but anyway, this is scientifically speaking, this is an abscess, and it is a draining abscess. You can see it's starting to drain. So usually the bacteria that cause these are Staph aureus are the biggest bugs that usually cause these infections. MRSA is also another one, and then anaerobes can also cause these infections, especially cellulitis, and sometimes abscess in patients who already have either immunocompromised situation or it's in the dental area. Anyhow, the treatment of course will be depending upon these bacteria. You can do penicillin, cephalosporins, Bactrim, you can do vancomycin, you can do some dicloxacillin. So you can do all those antibiotics that will target these bacteria. And then if you're suspecting anaerobes, then of course you will cover them with like clindamycin or antibiotics that cover anaerobes. When it comes to abscess, of course you always have to remember that draining the abscess will be the best thing to do. Usually it provides very quick relief, so try to drain it. Of course there is no point in draining cellulitis, there is nothing in there to drain. Another thing is lymphadenitis. So it's simply just infection of the lymph node. So usually cervical lymph nodes get enlarged and get infected, and that's how they present red, hot, tender, and they're just very big and swollen. So this is something to keep in mind. If it is a lymph node, don't think it's something that you have to drain right away unless it's causing symptoms where there's a lot of pressure. Usually these will resolve with either oral antibiotics or systemic antibiotics. So it's just a quick review of skin infections that can also cause fever, but not necessarily all the time. Then there are other causes of fever that are outside of this talk, so I did not cover these, but just remember that these can also cause fever. So fever of unknown origin, no surprise there, but obviously there's nothing to talk about here as far as the etiology is concerned because we don't know what causes it. Small percentage of patients come in with fever of unknown origin, which means fever has lasted for a while and no cause has been found. Atelectasis is fever that sets in the hospital, usually post-operatively. So people have pulmonary edema, usually it's very mild, and along with that they have some fever. Gout can cause fever, then a lot of inflammatory conditions in the body. So PE sometimes can have fever, MI patients can have fever, diverticulitis can cause it. People with viral infections other than flu can also get fever. Usually it's low grade fever. We didn't talk about in separate virus infections, but independently they can also cause fever. Some parasitic infections can cause fever. I didn't talk about those. And then any systemic inflammatory reaction. So you can see that a whole lot of other things can cause fever, but usually these fevers are not as dramatic, or usually these people will not present with fever as a chief complaint. They present with, for example, a red, tender, swollen, excruciating, painful big toe when they have gout. So they or shortness of breath with atelectasis or hypoxia. So they have additional symptoms that are usually the chief complaints of for them, but fever is not the chief complaint. It's just an associated finding, and it's usually low grade. So that's why I didn't cover these, but just want you to know that these are there too. The next section is antibiotics. So we'll quickly go over antibiotics, although we talked about antibiotics that should be used for various infections, but just as a whole, talking about antibiotics, remember this: we have different mechanisms of actions for all the antibiotics. So in this, remember your penicillins and cell wall synthesis inhibitors. So you have your cephalosporins and penicillins and some other antibiotics that will inhibit the synthesis of cell wall. Then your trimethoprim and sulfonamides, they will interfere with the folic acid metabolism, so just remember that. And then your ciprofloxacin, especially the cipro in the quinolone category, will cause inhibition of DNA gyrase. And this is an important antibiotic because we use it a lot whenever there are some abdominal infections or infections below the diaphragm. So that's why I remember how this works. Then you have your just a couple more here. So you have protein synthesis inhibitors. So you have 50S inhibitors and 30S inhibitors, and in that you have macrolide antibiotics, which are your azithromycins and then chloramphenicol and some other mycin drugs. And then you have 30S inhibitors, where you have your tetracyclines and gentamicin and all those mycins here. So this is just a quick review of the mechanism of action of drugs. Just remember specifically the folic acid metabolism inhibitors, DNA gyrase inhibitors, cell wall synthesis inhibitors, and 50S and 30S inhibitors. So this is what antibiotics are. And then quickly over how specific antibiotics will target specific bugs, and then what are their specific indications. So again, this is just a review slide. Quickly, there is no need to go into depth here, but if you want to spend more time on it, you can. This is just in the table form, just putting everything together. So you have your penicillins and amoxicillin. So this is all your penicillins, starting from the lower strength to the higher strength, and then in the end you have your clavulanic acid, which only just broadens the coverage for amoxicillin. So works for anaerobes as well. So that's why dog and cat bites are going to be healed with clavulanic acid, which when added to amoxicillin becomes augmented. So remember these penicillins. Then you have your nafcillin, oxacillin, doxycycline, which when added will target MRSA. So remember, NAF is for staph, and then your piperacillin and ticarcillin are even stronger. So they will cover all of these bacteria plus Pseudomonas. So P is for P. That's how you just remember this. And then you already know that head and neck and skin and chest infections, basically everything above the diaphragm is going to be somewhat covered with penicillins to some extent, sometimes greater than the other times. But anyhow, another quick one is about cephalosporins. So you have generation 1 through generation 5 cephalosporins, and you can see that they can also target pretty much all the bacteria that penicillins can target. But in addition, there is some broader coverage for E. coli, and then some broader for your H. influenza and Klebsiella. And then generation 5 will cover not only these but MRSA as well. Generation 3 cephalosporins will also cover Neisseria. So your meningitis and gonorrhea infections will get better with this. The next one is your aminoglycoside antibiotics. So these are your mycin antibiotics, or your gentamicin, tobramycin, and neomycin. So just these three, they are not very good. We don't like them very much because they cause a lot of toxicity. So we therefore use them now only in the setting of local problems. So you can use them as for local application. They don't work against anaerobes. They are only good for synergistic use. So there are three main toxicities that you got to remember. So your neurotoxicity, your ototoxicity, and nephrotoxicity. So non-NON, neurotoxicity, ototoxicity, and nephrotoxicity, those are very remarkable with these antibiotics. So try not to use them unless you really have to, but they are okay if you're using them for local application. Then you have your cyclin antibiotics, so your tetracycline, doxycycline, aminocycline. They are great for against four things. So those four are your mycoplasmas, your Lyme disease, rickettsia, and chlamydia. So you can see two of these are just like camping related diseases. Then you have your community acquired problems, and then you have your sexually transmitted diseases. So people who have acne, usually it's mycoplasmal problem, so they get better with tetracyclines. People who are hiking and camping, when they come back with fever and you're suspecting any of these two problems, you can use tetracyclines. But then of course there are other antibodies, for example cephalosporins, that will perfectly target Lyme disease as well. So just remember this, there is a limited use for these. Then you have your macrolides. So these are also mycin antibiotics, but they are better than these aminoglycosides because we can use them systemically. So all the community acquired things, your community acquired pneumonias, community acquired sinusitis, community acquired sexually acquired chlamydia, and then community acquired pertussis. So all these community acquired things will get better with macrolides. Usually the bacteria are your so you can just correlate it: mycoplasma, chlamydia, legionella, and pertussis. One important thing to keep in mind is that azithromycin is it's a very strong antibiotic. It's great for community acquired infections and also chlamydia, but it can cause arrhythmias. So keep that in mind, especially like if somebody has developed a new onset long QT syndrome, and they took azithromycin, then it was probably the cause. Then you have your sulfamethoxazole and trimethoprim, and the name for it is Bactrim. So this will cover your E. coli and Salmonella and Shigella. So simple UTIs will get better with it. Sometimes simple sinusitis and some of the other infections will also get better with it. We don't use them as much anymore also, but they are definitely, there's a big role for them for simple infections. Then the last is about your some of the stronger antibiotics, your fluoroquinolones. So remember your ciprofloxacin. So your bad UTIs, your prostatitis, and infectious diarrhea, those will get better. So all the gram-negative rods. Then your clindamycin will cover your anaerobes. So especially for dental infections, it's a great antibiotic. Also for infections in patients who have like lower extremity infections and they have immunocompromised state, so they usually have more anaerobes in their infection, so you can use clindamycin. Vancomycin is a big gun, so it will cover not only everything that penicillins and cephalosporins cover, but also MRSA. And if you see C. diff colitis, then you can do oral vancomycin. So for all the other infections we have to do IV, but for C. diff colitis we do oral vancomycin. Linezolid is the biggest gun, so it's one of the strongest antibiotics out there. It will cover not only MRSA but also vancomycin resistant enterococcus. So it will basically cover everything, and it's only used in the parenteral form. So this is another slide showing just antibiotics. So I color coded some of the antibiotics here, so I hope it's making a little bit sense, but just putting it all together. So you can see that everything above the diaphragm is, you have only 1, 2, 3, and 4 colors, so which means your cephalosporins, penicillins, azithromycin, and vancomycin. So just remember these first. So you have all your meningitis patients, not the encephalitis because that is your viral infection usually, but your meningitis patients will benefit from cephalosporins largely, but of course there are additional antibiotics that can be used too, like we talked about earlier. But this is just the key antibiotics that is used in these certain infections. So your otitis media patients will get better with penicillins and with cephalosporins. Pharyngitis patients and red pill infection patients will get better with cephalosporins, penicillins, and also azithromycin. Pneumonia will get better with all of these two, your penicillins, your azithromycin. Endocarditis patient will have to get vancomycin. And then okay, we already talked about pneumonia. So these are the head and neck infections. Then you start below the diaphragm. So you have your colitis, your cholangitis. So usually these infections will get better with your ciprofloxacin or fluoroquinolones. And gastroenteritis is usually, and myocarditis are usually viral infections, so there's no antibiotic for it. And then appendicitis, usually, although they are given antibiotics, but typically surgery is done, so I didn't add that here. And then you have your pyelonephritis patients that will get better with the usually with Cipro. If it's a simple UTI, then you can do Bactrim or trimethoprim sulfamethoxazole too. If it's a pediatric patient, then of course don't use ciprofloxacin, and in those patients sometimes we don't use Bactrim either if there is some allergy. So for pediatric patients, a simple UTI usually will respond to penicillins as well. Your PID patients, they will get better, of course, what is green, so cephalosporins, and then also your azithromycin, those can be given. Prostatitis patients will get better either with the, we already talked about it, so if you think it's an STD related prostatitis versus non-STD related, you can do ciprofloxacin in older folks, and then younger patients will get better with either azithromycin, or you can do cephalosporins. And then you have your osteomyelitis and septic arthritis. These are really bad infections. They can cause severe disability, so therefore they have to be taken very seriously. They will need usually IV antibiotics, so parenteral antibiotics will need to be given. So vancomycin will be the drug of choice in most of the cases. And then you have your skin infections and skin abscesses and cellulitis, so those can get better with your cephalosporins and penicillins. And so the color codes is all like green is all cephalosporins, your blue is penicillins, your yellow is azithromycin, and red is vancomycin, and then your brown is ciprofloxacin, and the rest that were not very specific, I just left them black. But anyway, I hope this makes sense. I don't know. So basically the 5 main drugs are something that you should remember. These clinically, these are used much more heavily, and the others are not used as much. But then you have, if you are suspecting like an infection where you need like a vaginal infection, then you can do metronidazole. And then we already talked about tetracycline and clindamycin. Anyhow, so let's leave this alone for now. So I'm going to, and then there are of course your Tamiflu for your influenza patients, ART for HIV, and chloroquine for malaria, and then RIPE antibiotics for tuberculosis.